So, good morning, good afternoon, good evening. This is Dr. Wouter Schievink from Cedars-Sinai in Los Angeles for our live Ask the Expert session. I'll be happy to answer any questions you may have about CSF leaks in general, particularly spinal CSF leaks and intracranial hypotension. This will be going on for the next, 30, 45, 60 minutes. Just type in the questions in the comment section below. And my assistant, Stacy Jean-Pierre, will read those questions to me. And I'll see if I can answer those.
So we have a first question. They'd like to know if there's any talk about studying the effects of long-term leaks on the brain.
Yes, there are some research projects going underway as far as that's concerned. These are mainly MRI scan projects. It's something that's called functional MRI scanning, and that's something that we are studying as we speak.
Another question, what are the different effects to the pituitary seen in high to low pressure, if there are any?
Well, if we're talking about the type of changes that you see on an MRI scan, generally patients who have low pressure, for example, from a spinal CSF leak, we oftentimes see that the pituitary gland is enlarged. That's a sign that sometimes is mistaken for a pituitary tumor. Sometimes patients with CSF leaks undergo resection of that pituitary tumor. So we have some material that has been examined under the microscope, and we know that the enlargement of the pituitary gland is basically just related to enlargement of the blood vessels within the pituitary gland, and the whole gland is enlarged. So it's not that there's a tumor, it's really expansion of the whole pituitary gland. The most typical abnormality that we see as far as hormones is concerned is that there's a increase in the level of prolactin. Now, for patients who have high intracranial pressure, oftentimes what we see on an MRI scan or a CT scan is something that's called an empty cella, where part of the brain that contains the pituitary gland, that is actually enlarged with spinal fluid. However, that is a very, very common finding on a scan, and certainly that by itself does not indicate that somebody has high spinal fluid pressures.
In regards to high pressure, can you discuss in detail rebound high pressure and ways to deal with it?
Well, we've been thinking about high pressure for quite a long time. I remember in the 1990s, we operated on a gentleman who had a spinal fluid leak in his spine from a ruptured cyst that had been going on for 10 years. And we treated that. We operated on the cyst, and then I would see him, the day after surgery, and he said, Doc, I still have headaches. And, of course, back then we didn't know that much about it. So I just thought that the surgery was unsuccessful, and we sent the patient home after a few days. And then he called me about 4 or 6 weeks later, and he said that he was losing vision in one eye. So we had him see an ophthalmologist, and it turned out that he had papilledema, meaning there was swelling of the optic nerves, and he actually had a little hemorrhage behind his eye. And we thought, well, maybe it's related to an increase in pressure. We thought if somebody has been leaking for a long time and you stop the leak, that the brain might take a little while to catch up to the new situation, and the pressure actually builds up. So back in the 1990s and even in the 2000s, we thought that it was a pretty uncommon type of scenario. But we now know that it's actually not that uncommon, and we see it about, I would say 20-25% of our patients who we treat for spontaneous spinal fluid leaks do develop high pressure. Typically, Really the most typical difference as far as headache is concerned, that prior to treatment, the headache generally is better laying down, while after treatment, in somebody who has developed high pressure, the headache is better when the person is up, and the headache is worse when the patient has been laying down. The headache might wake them up from sleep, and certainly the headache will be there when they wake up in the morning, and then when you're up and about and the headache is alleviated. We generally don't do a spinal tap to sort of, prove or disprove that, because we've seen quite a few patients who, even with very small needles, then develop a spinal fluid leak again because the pressure is elevated. I usually recommend sleeping on an extra pillow. If that doesn't work, you can take something that's called dandelion tea. It's sort of a natural diuretic that seems to work. And if that doesn't work, then we have to resort to some type of medication. Usually we prescribe a medication called Diamox or acetazolamide. That's a really good medication to lower the production of spinal fluid, but it has quite a few side effects. About 30-40% of patients eventually have to stop taking that medication or lower the dose. So then we can give medications like Lasix, for example, a diuretic. And almost always it's a self-limiting process. Doesn't last for more than a few weeks or months, and only very, very rarely does it last for more than a few months or a year. We recently completed a study looking at the outflow of blood from the brain, and it seems that people who have some obstruction of certain blood vessels in their brain are at a higher risk of developing this rebound high pressure.
After having a leak for many years, I more recently have gotten additional side effects that I did not have during the first couple of years, such as brain fog and vertigo. Does that mean my leak is getting worse, or that I may now have permanent damage from having a long-term leak?
Well, I don't know if it necessarily means that the leak is getting worse. It just means that it has not been cured. I do not think that it's very likely that it means that it's something that's permanent, because we know that even people who've had this for 10, 20, 30, even 40 years, that once the spinal fluid leak is repaired, that really all of those symptoms are still reversible.
Is a fibrin glue patch more effective than a blood patch?
Well, for a fibrin glue patch, you really need to have a target. So that doesn't necessarily mean that you know exactly where the leak is coming from, but you have to have a general idea. Or you can address larger cysts along the spine with glue, whereas for a blood patch you don't need to know exactly where the leak is located. Fortunately, the vast majority of people who have spinal fluid leaks are cured with 1 or 2 blood patches. Those patients oftentimes, they don't really remember that so well after a few years, and when I contact those patients, they've forgotten who I am, and they sort of have forgotten about that episode. I think it's important to realize that most people who have leaks really are cured with 1 or 2 blood patches. If there is a good source for the leak that's been identified with some type of imaging, then it does appear that glue injections are more likely to cure the leak than directed blood patches.
Does a blood patch work while on baby aspirin?
Well, nobody's ever studied that in any sort of scientific fashion. But yes, it should work even when you're on baby aspirin. Once the blood patch is delivered in the epidural space, there really is no more effect of the aspirin. So an aspirin, blood thinners even, can be given after a blood patch has been delivered. Really should not affect that blood clot that has been injected, because it does not have any contact anymore with circulating blood. So you certainly can have a blood patch done and take aspirin, and you don't have to worry about it becoming less effective.
What are your thoughts on pregnancy after a CSF leak has been determined? Any precautions you recommend?
Well, that's a really good question, and generally what I recommend is that for people who have a spinal fluid leak and it's still present, is try to avoid getting pregnant. If that person does become pregnant, then interestingly we've seen some people feel much better during pregnancy, particularly towards the third trimester. But we've also seen people who get worse during pregnancy. Of course, the treatment is limited during pregnancy, and even though we've performed many epidural blood patches in pregnant patients, clearly you really want to limit any sort of imaging that involves x-rays. Now, for patients who have been treated for a spinal fluid leak and then become pregnant, there is a certain risk of a recurrence during pregnancy of the spinal fluid leak. I think that risk is very, very low, and I certainly don't think that that should preclude pregnancy for those who wish to become pregnant. And then as far as the delivery is concerned of the baby, I generally recommend just regular vaginal delivery if that's what the wishes of the mother are. Generally, a lot of obstetricians, are a little bit less eager to go ahead with a vaginal delivery, and they'd rather do a cesarean section. I don't think that's necessary, but I would say 80-90% of patients we've treated who have become pregnant do go on to have a cesarean section. And that's not just here in the US, but that's also in Europe and Asia. As far as the sort of anesthesia that you would give during the cesarean section, I think a spinal anesthetic would be preferable over an epidural. With a spinal anesthetic, of course, you do know that you're going to penetrate the dura, but the needle is much, much smaller. And with an epidural, it's a little bit of a larger needle, and of course you can cause one or more tears of the dura. So if anesthesia is contemplated, I prefer spinal over epidural anesthesia.
How long do you wait after a blood patch to return to full physical activity?
Well, that's another something that has not been looked into in any scientific fashion. We usually recommend to limit activities for about a month. Some of my colleagues recommend 6 weeks or 8 weeks. Some people recommend 3 months. 15, 20 years ago, I would admit patients after epidural blood patches to the hospital for bed rest. That doesn't really seem to make any difference at all. So after epidural blood patching, we usually have the patient stay in our recovery room for a few hours. Then they can go home or go back to the hotel. We do want them to limit their activities for a month to 6 weeks, maybe 8 weeks. And with that I mean try to avoid lifting anything over 10 pounds. Try not to twist or bend the spine. Try to refrain from straining when you have a bowel movement. And then for people who go to the beach, it's probably best to avoid walking on the soft sand. That causes a lot of straining on the back, and just try to limit your walking to walking on the hard sand. And then try to, not to twist or bend your spine. But again, nobody has good data for that, so I wouldn't be all paranoid about it. And if something needs to be picked up, just bend through your knees and pick up whatever it is that needs to be picked up.
If you have gotten worse after a blood patch, is it more likely that an additional leak was created, or can there be another reason why a person would get worse after a blood patch?
Well, there can be many reasons for why a person could be worse after a blood patch. One of them could be because of the rebound high pressure that we've talked about. And we generally consider that a good sign. However, of course, if a person has an epidural blood patch and that person does not have an underlying spinal fluid leak, for example, if I would have an epidural blood patch, I would definitely have a high pressure headache, So that's something to think about. The other thing to think about would be having caused a leak. About 3-4% of the time, the epidural blood patch actually, inadvertently the needle goes through the dura. Of course, most of the time that leak is repaired right away because a blood patch is placed. Another reason that a person could be worse after an epidural blood patch could be if, inadvertently some of the blood gets injected into the subarachnoid space or the subdural space, and that can cause severe headache or neck pain. That's something that can be treated with steroids, and they usually, will take care of that type of situation within a day or so.
Is severe rebound high pressure a good indicator of a leak if a leak wasn't found on imaging?
Well, it can be. So for people who really have a spinal fluid leak, that is a good sign. But again, for people who do not have a leak, a lot of those people also will have symptoms of high pressure. Maybe not everybody, but certainly the vast majority.
What causes intermittent leaks, and are these harder to find and treat?
Yes, we do think that some patients have intermittent leaks. We mainly base that on the history. So, some patients will tell you that they've had symptoms of a spinal fluid leak for a few days or weeks or months. Symptoms spontaneously go away. Patient might be without any symptoms at all for a period of time, and then these symptoms start up again. We've had several patients where we've actually been able to image that. So, we see abnormalities of the brain MRI or abnormalities on spinal imaging that then will resolve, and then symptoms and imaging abnormalities return again. But that's certainly a minority of patients who I think do have intermittent leaks. Finding intermittent leaks on imaging is difficult, and it certainly could be a reason why up to 50% of patients who we know must have a leak, that we're not able to identify the leak. It could just be that sometimes the hole in the dura, that membrane that covers the spinal fluid, is very, very small, and it can spontaneously close up, and then with any sort of increase of spinal fluid pressure, the hole opens up again. I think sometimes the spinal cord can drape itself over a hole in the dura and can then seal the leak just by that. And then when a patient changes their position, the hole opens up again. We've seen that when we do these dynamic myelograms. We have, certainly in the past, not so much anymore because the yield is very, very low. We've had patients, do jumping jacks, jog around the ward after we inject the dye for the myelogram before we get a CT scan. That doesn't seem to be a really good way to find intermittent leaks, though, so we don't really do that anymore.
How long can you expect on average for rebound high pressure to last?
In general, it lasts for less than a few weeks. It's a little bit difficult to determine the exact duration because we are fairly aggressive in treating rebound high pressure headaches. So, if these conservative measures that we discussed a few moments ago, if that's not enough, and we place the patients on medication, we keep them on the medication for about 3 or 4 weeks and then taper the patient off of the medications.
For those who have a confirmed leak and have been leaking for quite a long time, is there any new treatments that are being thought of or are being investigated?
Well, we certainly continuously think of new treatments, and sometimes it's difficult to investigate that right away. It has to go through a certain process in most medical centers, but there certainly are, different diagnoses, different ways of making the diagnosis of a spinal fluid leak, and different treatments on the horizon.
Are there any medications that can help with CSF projection while waiting to be evaluated, such as Florinef? And does low vitamin D make you prone to dural tears?
Yeah, I think some patients do improve with Florinef or midodrine when you give that at a fairly healthy dose. When patients need to wait a while to be treated, we sometimes prescribe steroids. Of course, steroids have a lot of side effects, but most patients who have spinal fluid leaks get tremendous relief of symptoms with steroids. Of course, it doesn't treat the leak, it just masks the symptoms.
Are spinal cysts likely to be the source of a leak? And if so, do you take the cysts out, especially when pressing on nerve root?
Well, I think it's important to realize that it's not that rare for a person to have one or two spinal cysts when they're very small. That's a common finding. Certainly, patients with spontaneous leaks have more and larger spinal fluid leaks. Have spinal arachnoid cysts. Before we did digital myelography, we would, in those patients who have recurrent symptoms after blood patching, we would address the larger cysts with either surgery or with glue injections. Nowadays, with digital myelography, we're sometimes able to, identify the exact cyst that's leaking. But even with surgery, when you operate on the largest cyst or any cyst that's present, the success is not 100%, it's about 80%. And the reason is that for people with spinal fluid leaks, we know that even if the cysts are very large, that's not necessarily where the leak is coming from. The underlying abnormality is a certain weakness in the dura, and that means that those individuals have developed cysts, and they also have developed a spinal fluid leak. But it doesn't necessarily is at the location of the cyst.
Can a blood patch given in the lumbar area help if a leak is suspected to be in the cervical area but has not been identified?
Yes, I mean, we know from experience, like we mentioned before, that the vast majority of leaks are cured just with simple, straightforward lumbar epidural blood patches. Even in patients who have a leak at a completely different level. What we usually do, especially if we don't know exactly where the leak is, we place the patient with their head down after blood patches so that the blood will move freely from the very lowest to the very highest levels of the spine.
Why is there such a high rate of CSF leaks in EDS, Lyme, and mast cell patients?
Well, we know from experience that the majority of patients who have spontaneous leaks have some type of underlying connective tissue disorder. And we've been studying that since the 1990s, but really nobody has identified the precise gene or group of genes that is involved in this. Ehlers-Danlos syndrome is one of the syndromes that is associated with a higher risk of a spontaneous leak. We don't know exactly why that is. The simple thinking is that it interferes with the integrity of the dura, but there might be a totally different mechanism that's going on. Of course, for the Ehlers-Danlos syndrome patient population we're talking about, it's probably a very varied type of population. Nobody has been able to identify the genetic defect in the type 3 Ehlers-Danlos syndrome group of patients. And I think there's a wide variety of different genetic abnormalities that are involved in this.
Is there a reason why some leaks heal by themselves and some do not?
Yes, and if I only knew what that reason would be, that would be very helpful. I think it probably has to do with the underlying strength of the dura. I think it has to do with the pressure of the spinal fluid. So, for example, some patients have high intracranial pressure, something that's called idiopathic intracranial hypertension. And certainly those patients, even though their original spinal fluid pressure is very high, those patients are at an increased risk of not only skull-based spinal fluid leaks, and that's been established really well, but very most likely also leaks in the spine.
What causes the formation of a fistula that allows CSF to flow into a vein?
Well, I think that a lot of times what happens is that a person has a spinal fluid leak. There's a lot of spinal fluid outside of that sac that contains the spinal fluid. And as a reaction to that, the body dilates a lot of these blood vessel structures, including the epidural veins within the spine. And then, even though the initial leak is repaired within days, weeks, months, sometimes some of those channels of the dilated blood vessels persist, and that then forms one of these spinal fluid to venous fistulas. In other patients, I think it's more of a primary mechanism, but I think that in most of them, it's probably a secondary mechanism that's related to the original spinal fluid leak.
Can you be diagnosed with rebound high pressure without signs of papilledema?
Yes, you definitely can. And in a group of patients who we studied recently, only about 10 or 15% of patients who we diagnosed with rebound intracranial hypertension actually had papilledema on fundoscopic examination. But there is a caveat to that, is in that most of those patients were not investigated by an ophthalmologist, but rather by a neurologist or by myself. And we know that ophthalmologists, when they dilate the pupil, are much better at diagnosing papilledema than we are. But it certainly does not preclude the diagnosis of rebound intracranial hypertension.
Are stem cells and gene therapy the future of healing this disease? And if so, can you speak on any advancements or why there are none?
Well, we have used some very simple type of stem cell therapy that was not successful. We certainly need to do a lot better in research as far as identifying the underlying genetic abnormalities in patients with spinal fluid leaks. And again, it's probably a very heterogeneous group of disorders, and only then can we talk about any sort of genetic therapy. But these are things that are, very many years in the future. So although now we know a lot more than we did, 5, 10, 20 years ago, I know that in the years to come, there's going to be a lot of discoveries.
Can rebound high pressure following a blood patch cause a patch to blow or induce a new tear such as a cyst filling or breaking?
Yeah, I think that situation can occur. I do think that with any type of treatment, not just with blood patches, but also with glue or surgery, or even spontaneous resolution of a leak, I think that can precipitate either the same leak occurring or a leak from another site along the spine.
How important is it to do a spinal tap or otherwise measure ICP to evaluate a leak or before proceeding with a leak repair?
Well, we've known, since last century that quite a few patients with leaks have a normal spinal fluid pressure. And whether that's measured through a lumbar puncture, a spinal tap, or measured with intracranial pressure monitoring, that doesn't really matter. It's really more of a volume type of phenomena. It's not so much a pressure type of phenomena. So there was a time that I did not want our radiologist or whoever did the spinal tap to even measure the pressure because people spent so much time thinking about that, and we know it's not really a pressure phenomena. Of course, the more information the better, so nowadays we do measure the pressure very carefully on everybody. And it sometimes can be helpful, but we try to be a little bit more practical in this. And it's very rare that I recommend intracranial pressure monitoring, but certainly other medical centers do that on a very routine basis, and I'm looking forward to reading their results this year and next year. But we tend to not be too invasive with measuring pressures.
What is the best way to find a cranial leak?
Well, the best way to find a cranial leak really starts off by measuring the fluid from the nose or the ear for something that's called beta-2 transferrin, which is something that usually takes a few days to be measured. It's something that's only present in spinal fluid. It's not present in tears or blood or urine. And that's really a very good way, non-invasive way of determining whether or not the fluid is cerebrospinal fluid. Once that's been determined, and it needs to be looked into a little bit more detail, and we need to know exactly how that fluid gets through the skull base. We usually do a procedure that consists of a single spinal tap, and then we inject a dye that will show up on the CT scan. And usually, but not always, we also inject a radioactive tracer that can then be evaluated later at an interval of anywhere from 2 to 48 hours, depending on the particular situation.
Does bulging disc throughout the spine indicate a possible leak?
No, bulging discs throughout the spine are common. Right? Basically, everybody over the age of 20 has bulging discs in their spine. Certainly does not mean that that's where the leak is coming from. And we also, of course, have known since last century that certain bulging discs, but really only those that are associated with a sharp little piece of bone that's either rubbing against or sticking through the dura, only in that situation would it be related to a spinal fluid leak.
Does a cervical blood patch have more risks than having a blood patch lower in the spine?
Yes, it does. The reason that the vast majority of epidural blood patches, certainly early on in the course of a spinal fluid leak, are performed in the lumbar spine is because in the lumbar spine, which is the part of the spine below where the ribs are, that there is no spinal cord there. So there's really essentially no risk of damaging the spinal cord. For blood patches or glue injections in the cervical spine, where there is a very important portion of the spinal cord, there is a certain elevated risk to the patient.
Since high pressure and low pressure symptoms can sometimes mimic each other, is it dangerous to have a blood patch if you are actually in high pressure and not low pressure?
Well, I think it certainly can make the symptoms worse. I don't think there's any risk of any permanent danger to that. The way that we usually place the blood patches is that while the needle or needles are placed, the patients are given some intravenous sedation. Once the position of the needles is confirmed, then we stop that sedation, and when the patient is awake, we start injecting blood because we think that the more blood is injected, the better the chances are for a cure. But we oftentimes are only able to inject a few milliliters of blood, and that might indicate that the underlying pressure is actually elevated.
I have read that depending on if the leak is suspected to be a slow leak or a fast leak, it may affect what kind of scan is being ordered. What signs do you look for to determine if it is a fast or slow leak prior to the myelogram?
Yes, there are many different types of leaks, and that certainly plays a big role in the recommendations as far as imaging is concerned. The way that we image the spine is we usually start off by doing something that's called an MRI myelogram, which is a non-invasive test, does not involve a spinal tap. And it's really an MRI scan that specifically looks at fluid, particularly spinal fluid, along the spine. That's a really, really good test. If that test shows that there's a very extensive collection of fluid outside of the dural sac, that almost always, not always, but almost always indicates a fast leak. We would not do a CT myelogram in that circumstance, but we prefer a test that's called a digital subtraction myelogram, which is basically a test where the radiologist inject dye into the spinal fluid, and then the radiologist take a video, about 2 frames per second, of the dye as it traverses the spine. And that really is the best way of looking for a fast leak. For looking for a slow leak, we sometimes get delayed imaging. We sometimes inject gadolinium, which is an MRI contrast agent, into the spinal fluid. It's important to make sure that it's diluted gadolinium, else there's a high risk of damage to the central nervous system. And that sometimes is helpful in detecting very slow leaks.
For those who are unable to see a specialist, are there any ways to self-heal?
Yes, I think bed rest is always a very good way of trying to heal the leak by itself. I don't think that bed rest needs to be longer than 48 or 72 hours. But certainly early on in a spinal fluid leak situation, bed rest can help and can seal the leak. Other things that a person can do is something that's called an abdominal binder. It's like a corset with Velcro. That's not something that cures a leak, but a lot of patients who have spinal fluid leaks feel a lot better when they wear the binder. And then during that time, the body has an opportunity to seal the leak itself. Whether or not certain vitamins or supplements are helpful, that's never been proven, so that's really not something that I can recommend.
Can a blood patch resolve a leak caused by a disc impinging on the dura?
Well, blood patches can help fix any type of leak, including leaks that are caused by disc herniations, particularly these calcified little bony spicules, even those that penetrate the dura. But I've really only seen good results with that when it's early on in the course. So when blood patches or directed blood patches, directed glue injections are done early on after a leak, and with that I mean weeks or months, then there's a good chance of sealing even those leaks. When it's a leak that's been present for many years, the results are not as good.
In an EDS patient with many levels of meningeal diverticuli in the spine, could these multi-level diverticula cause enough negative pressure to cause an acquired Chiari malformation?
Yes, that's a very common scenario that we see. It's unusual to actually have negative pressure, but we have seen that as well. So that means that when you perform a spinal tap, actually air is sucked in through the needle. That's an uncommon scenario, but certainly large cysts in somebody with Ehlers-Danlos syndrome can either cause a acquired Chiari malformation because the cyst is actually leaking spinal fluid, or even just by the fact that the cysts are so large that when a person is up and about, the spinal fluid pools into these cysts and creates a state that's the same as if a leak is present.
Is there a link between developing a leak after taking a fluoroquinolone?
Well, that's certainly something that has received a lot of press. And after somebody told me about that, I've been paying more attention to that. And just this month, I happen to have seen 2 patients who developed symptoms of a leak after taking these medications. What I think is important is to look into this in a scientific, rigorous fashion. These are antibiotics that are quite common, so we don't really have a definite answer yet.
Is it possible to cycle between high and low pressure?
Yes, I do think that's something that in the past has been overlooked. Most of the time that happens after treatment, but we've also seen patients who spontaneously cycle between high and low pressure. So in other words, the original problem is a spinal fluid leak. Spinal fluid leak is sealed by itself. Then the pressure builds up. Then the person gets symptoms of high pressure. And then the high pressure can reopen the leak again. The person can go into a low pressure state. We see it more often after treatment, of course, but you can also see it spontaneously. And the time course of these cycles can be very short. In other words, can be hours, but it also can be weeks or months or even years.
What can we do as patients to educate doctors closer to home who many times are ill-informed and or dismissive as relates to CSF leaks?
Yeah, that's a little bit difficult to answer. I think we as doctors, particularly as surgeons, we don't really like being told what to do. Not only by patients, but also by other physicians. I think some people, including doctors, you will never have them listen to you. So then I think you should find a different doctor. But I think most physicians will become interested in this. But I don't really have a good way of recommending how to have the doctor become involved, just because everybody has different personalities. I think the wrong way to do it is to bombard people with too many questions. But again, most physicians are interested in learning, so perhaps writing a short synopsis, maybe including an interesting article from a scientific journal, might be just a way to convince doctors that this is something that's real and it's not something that's very rare either.
Is it possible for a patient to have both a cranial and spinal leak at the same time?
Yes, it's possible, and we've seen that. It's just very, very rare. A more common scenario is that somebody has a skull-based spinal fluid leak from whatever reason, spontaneous, following a neurosurgical procedure, and then after that has been fixed, then develops a spinal CSF leak.
If blood patches progressively help but don't fully resolve symptoms, up to how many patches would you do?
Well, it depends, on many different things. Number one is the wish of the patient, right? If we have a different, better way of treating the leak, whether that's a glue injection or a surgical procedure, some patients want to skip even an epidural blood patch. I'm usually against that. Other people, will do anything to avoid surgery and have no problem having dozens of blood patches. And all those different scenarios are very, very reasonable. So there really is no maximal number of blood patches. I've operated on people who've had as many as 70, 75 blood patches. And I've operated on patients who've not had a single epidural blood patch, although that's quite rare.
Can leak symptoms change from day to day in their severity?
Yes, I do think that happens. The reason for that is unknown, but it could be that it's an intermittent leak, that sometimes that slit in the dura sort of is half closed, or it could just be related to the ability of the brain to produce more spinal fluid. There's just no way of measuring that.
Can you have brain sag without a leak?
Well, I do think that can happen. I think some patients who have brain sagging, particularly patients who have a connective tissue disorder that's called Marfan syndrome, can have brain sagging without a leak, and it's the type of situation that we discussed earlier, where there are very large sacs of spinal fluid in the spine, particularly lower in the spine, and the fluid just pools there when the person is up and about.
After a while, can you get brain damage due to a leak caused by an epidural?
Well, I think it's unlikely to have permanent brain damage from a leak, whether that's caused by an epidural, a spinal tap, or a spontaneous leak. Most of the time, that is something that's reversible even after many, many years. One of the rare exceptions would be a person who has so much brain sagging that they become comatose, or if there's bleeding in the brainstem or the middle portion of the brain.
Can a leak cause pain in your limbs?
Yes, so certainly some patients with leaks have pain in their arms or legs, and that's either related to large cysts that are present that just coexist with the leak, or if there's a leak that's sufficient enough that it causes sagging, stretching of the nerves going to the upper extremities mainly. And then when the leak is fixed, those sort of symptoms in the arms and legs should resolve.
If your symptoms are not acute and you are high functioning, but your brain imaging continues to show brain sagging, is it dangerous and bad for your brain long term if you do not seek treatment?
Yeah, what a great question. I don't have an answer to that. I certainly think if there are no symptoms, there is no need for treatment. But having said that, I do think if a person, and this is what I usually recommend to my patients, so if an individual still has a leak and there are abnormalities on the brain MRI, or we see the leak on the spine MRI, then I usually recommend yearly MRI scans.
If an MRI shows low pressure symptoms, but headaches seem to follow high pressure symptoms, do you still treat?
Yes, so we've known for about 20 years or so that some patients who have extensive spinal fluid leaks have sort of the reverse type of symptoms. So some patients who have a large leak actually feel better when they're up, and they feel worse when they lay down. That sort of paradoxical headache is not explained that well. Some of us think that the reason might be that when there's a leak of spinal fluid, we all know that the blood vessels can dilate, and we think that some patients who have dilated blood vessels in their brain, that dilation actually sort of exceeds what's really necessary, and that could be a reason for this sort of paradoxical high pressure type headache, even though the spinal fluid leak is present.
For some patients, multiple blood patches attempts are necessary. Do these patches build upon one another, or once they fail, no more can be done?
No, I do think that more often than not, the results of the blood patches are cumulative. So that after a blood patch, even though the symptoms might recur, even to the same degree that it was previously, I do think that the results of subsequent blood patches are better and are cumulative. Of course, one thing to bear in mind is that in some patients, at least, it becomes more difficult to place blood patches, particularly after a person has had many, and we usually think that that's related to scar formation.
How long on average can it take for all symptoms to resolve once a patient is sealed? For example, the headaches are gone, but all other symptoms are still there.
Well, for example, we do think that headache is probably the first thing that improves after a leak is fixed. And I think the last thing that usually improves is the situation where a patient has double vision when they look to the side, and that's caused by damage to a little nerve that's called the sixth cranial nerve. And that's a nerve that's very, very delicate, and even when a leak is fixed, it can take weeks or even months, up to 3 months or so, for that nerve to become fully functional again. And then the other symptoms are sort of in between that. So again, headache is usually the first thing that improves. The problem with that particular nerve coming out of the brainstem takes the longest to improve.
Have you seen patients who develop a leak following a lumbar puncture have a different location in the dura that is punctured? Meaning, can you have a leak in another location after having a lumbar puncture?
Yes, well, sometimes it's really a conundrum. So let's say a patient comes into the ER with headaches, and the ER physician suspects meningitis. They do a spinal tap, terrible headache, and then when they come to see us, we see, for example, many different cysts along the spine, and then it becomes sometimes a little bit of a puzzle. So one scenario could be that the headache was from something completely different. The spinal tap actually caused the spinal fluid leak. The presence of the cysts indicate that the dura is a little bit more delicate, and that's why it's difficult for the body to repair the leak. Or it could be that the initial headache really was caused by a spontaneous leak, possibly related to the cyst, or certainly related to the underlying weakness of the dura. And sometimes it's really impossible to differentiate those two scenarios. The treatment for those, of course, is a little bit different, although the initial treatment would be just to proceed with epidural blood patching.
Are there any risks or dangers of flying, traveling while in low pressure or high pressure?
Well, most patients tolerate flying really well, whether it's with low or high pressure. For patients with low pressure headaches from a spinal fluid leak, about 70% or so really don't feel any difference during flight, except if it's related to being in an upright position much. About 20% of patients actually feel better, usually with takeoff or landing, but about 10% of patients feel worse during the flight. Most commercial airliners are pressurized to about 8,000 feet. When patients travel from far away, I do recommend air travel, just basically because most patients who decide to drive cross-country, or they rent an RV, a lot of those patients will call back after 24 hours and tell us that they went back home and just are planning on taking a flight, just because it's difficult to travel large distances on the highway.
How long does it take the blood to dissolve after a blood patch?
Yeah, we have some good data on that just by getting MRI scans after blood patches. Usually blood patches are visible up to about 3 to 5 days. After 5 days, it's really unlikely to still see the blood in the epidural space, at least on MRI scans. If for some reason a person has surgery after epidural blood patches, we do see the remnant of the epidural blood patch, and basically that's a thin layer of scar tissue overlying the dura. If with an epidural blood patch, some of the blood inadvertently has been injected into the subdural space, so that's the space within that dural sac, then the blood can stay present on MRI scans for weeks or even months. And when I started becoming interested in spinal fluid leaks in the 1990s, some usually older anesthesiologists would contact me and say, what you guys should do, you should try to inject the blood into the subdural space, because the idea was that that might be more effective. But it's really difficult to actually, find that space with a needle, and certainly the risks of a subdural blood patch are much greater than with an epidural blood patch.
Is it possible to develop a spontaneous leak many years after having an epidural during childbirth?
Yes, that's not an uncommon scenario, because epidurals are used a lot in this country during childbirth, and spontaneous spinal fluid leaks are more common in women than they are in men, and they are particularly common in the 5th and 6th decade of life, right? Meaning in the 40s or 50s, after most women have had children. So that's a pretty common scenario.
Is it possible to have a leaky dura without having a specific tear?
Yes, I do think that can happen. So sometimes I've operated on patients, and the dura, basically looks like wet blotting paper. And even though I don't see, spinal fluid pouring through the dura, I certainly then imagine that when that person is upright, of course, during surgery, the person is laying down, but when the person is upright, that there's a certain, spinal fluid transport through the dura, and it would be like, tears coming through the dura.
Do you see many cases of CSF leaks without having brain sag?
Yes, we see brain sag in less than 50% of patients with spinal fluid leaks. And that includes patients with very, very extensive spinal fluid leaks who have no brain sag, who have a completely normal brain MRI.
Do you know what causes tinnitus in low pressure and in high pressure?
Well, we think it's either related to the pressure phenomena itself, or it could be related to sagging of the cranial nerves causing tinnitus. So either it's related to the pressure, or it's related to abnormal conduction through the nerve.
If a connective tissue problem is suspected in a patient, what, if any, are the benefits of getting genetic testing and diagnoses?
Well, I think for some genetic disorders, for example, Marfan syndrome, it is very, very important to see a geneticist. There are many different things that need to be looked into that have, potential life-threatening implications. I think for the vast majority of patients with spontaneous spinal fluid leaks, genetic testing would be of interest, certainly to the patient, also to me, but the practical implications are somewhat limited, and mainly that's because we have not really been able to identify the gene, and it's very rare, even for a geneticist, to find a real named type of connective tissue disorder in these patients. But having said that, we usually do screen patients for different type of problems that can happen in the connective tissues for those with spontaneous leaks.
Are there any studies showing a relationship between leaks and tremors?
Well, for some patients, particularly those who have a very significant brain sagging, tremors in the upper extremities, but sometimes also the lower extremities or even the head, are common. And sometimes those individuals are diagnosed with, for example, Parkinson's disease. But the tremors are really caused by the spinal fluid leak. And then again, that's almost always in the situation where there's significant brain sagging.
Can you explain what a pseudomeningocele is?
A pseudomeningocele is really a collection of spinal fluid that's not covered by the normal dura, but it's covered by either a pseudomembrane, meaning certain scar tissue that the body has produced, or it's really just a collection of spinal fluid within a certain space of the body. So for example, after somebody has spine surgery where inadvertently the dura was injured.
Do you recommend periodic brain imaging for long-term leakers?
I recommend brain imaging until the point that the brain imaging has become normal. For patients who have been treated for a leak and they no longer have any symptoms, we usually follow the brain imaging until it's normalized. And then again, like we discussed previously, some patients have no symptoms, obviously do not desire any treatment, but the brain imaging is still abnormal. And in that situation, I usually recommend yearly follow-up imaging. Some patients with persistent leaks can develop certain abnormalities in the brain that prior to those abnormalities becoming symptomatic, we can easily identify those on a brain MRI.
Can you do surgery without knowing the location of a leak?
Yes, and certainly in the olden days, that was almost the norm. So there was a lot of exploratory surgery in the, let's say before the year 2000, 2010. Nowadays, we're almost always able to identify the exact source of the leak when the leak is present. So now that's really not so much the routine. Rarely, if a leak extends over several levels and we don't really know where it's coming from, I will perform what I call exploratory surgery. We've also developed different surgical treatments for patients who we know must have a leak. We just cannot identify it. But these are not specifically meant to fix the underlying leak, but rather to provide symptom relief.
When can you exercise after a sealed leak, and what type of exercise?
Well, pretty much, any time after a blood patch or surgery or a glue injection, walking is a good exercise. Up and down stairs is a good exercise. Anything that makes a person feel worse, don't push through it. Just stop doing whatever it is you're doing and then pick it up later. But generally, besides walking, I really don't want my patients to exercise up until about a month after treatment, regardless of what that treatment is.
Where does the CSF fluid go while leaking?
Well, some of that spinal fluid gets absorbed by blood vessels, but it can also leak into the muscles. It can leak into the lungs, or rather the space around the lungs. It can leak in the peritoneal cavity in the abdomen, and then it can leak into the kidneys as well.
Why do some people seem to have so many symptoms and feelings of brain sag without actually having brain sag?
Yes, unfortunately, nobody really knows why that is. So again, there are patients who have debilitating symptoms. There is a leak, and the brain MRI is completely normal. So whether in those patients it's a different mechanism, or if it's just such a subtle difference that you cannot see it on the MRI, nobody really knows. Well, I think it's been about an hour. So maybe it's time to wrap up. Maybe there's one more question.
For those with identified Tarlof cysts on the spine, what are some of the things to avoid, if any?
Well, Tarlof cysts, particularly in the sacrum, are a very, very common finding. So if there are no symptoms, there really are no limitations as far as what a person can do. If a person does have symptoms of the Tarlof cyst, if it's a spinal fluid leak symptom, then best to avoid anything that would make those symptoms worse.
How long does it take for a sagging brain to return to normal in imaging after treatment?
Well, that's variable. It can actually occur within 2 or 3 hours from surgery. We've seen that. And in other people who we know the leak has been fixed, we do a spine imaging before and after treatment. It can take up to about 1 or 2 months. If after 2 months there still is brain sagging, then that really means that there still is a leak that's present. All right, thanks everybody. Thank you, Stacy. Later on today, Dr. Ian Carroll from Stanford will have a live session. I'm going to be watching that, and I wish everybody